Yeah. So Dr. Rapoport is a professor at UCLA. He is in neurology. He has a background. He is actually, he did medical school at SUNY Downstate Medical Center. He finished back in 1966, and then he went to do his neurology training at Mount Sinai. However, he had like a internship year at Maimonides Medical Center. Then after this, he has been having a training in an NIH for neuromuscular, and he had some private practice in Connecticut. He then has a additional training in headache, and he has a extensive additional like endeavors. So like he's been involved as a past president of International Headache Society. In addition to this, he has been participating in like multiple articles, chapters, and posters about headaches and other neurological diseases. He's currently also editor of Headache, CNS Drugs, and the editor-in-chief on Neurology Reviews. And he has participated as a peer review in other journals. He, addition to this, he has also endeavors as a CEO and co-founder of IT health company. It's called Montage. And he accepted our invitation. He was very happy to be back to Downstate. So I'm gonna give all this spotlight to the Rapoport.
Thank you very much, and good morning, everyone. And I hope I've heard that many of you are interested in headache, and some of you will even be taking fellowships. And we need more people interested in headache. When I went into headache, it was not very popular because we had almost no medication. The science wasn't very well defined. And people thought that headache was psychological way back. And in fact, it's become a very exciting field with wonderful advances. And so I'm glad some of you might. So, you can still hear me, I assume. So here are my disclosures. And I'm going to start by talking a little bit about the history of MOH, the epidemiology of MOH. We'll talk about the diagnostic criteria and how they've changed over time, the controversies in the field, which medications are overused, the pathophysiology as we understand it today, the clinical presentation, which any of you that have seen a bunch of headache patients, you know about how it presents. What is the treatment that we've been using over the years, and some exciting new treatments, and a little bit of the literature about that. And what's the prognosis of these patients, and I'll summarize and conclude. So I first learned about medication overuse headache from Dr. Lee Kudrow, who happens to be the father of Lisa Kudrow from Friends and many movies. And he is a headache specialist, older than I am. And he taught me that when patients use too many acute care medications, that they actually get worse. And he wrote his first paper in 1982, but he taught me this in 1979, the year I decided to start shifting into headache. At the very same year, Hans-Rudi Eisler from Switzerland also wrote a chapter in a book entitled Migraine Treatment as a Cause of Chronic Migraine. My first paper on the subject was in 1988 in the journal Headache. And back in those days, we called this problem analgesic rebound headache. But we now know that it's not just analgesics that can do it. Triptans can even do it. And we don't call it rebound. We call it medication overuse headache, which many people don't like that term because it implies that the patient is doing something wrong on purpose. And we know they're doing something wrong, but probably just to feel better. The epidemiology is pretty much the same in many countries of the world. It's approximately 1% of the general population that has MOH. It's more in women than in men, 74% versus 26% in this one study. And there are some outlier countries. Russia has 7.6% of the population, Iran 4.6%, and China is actually below 1%. If somebody comes into a headache specialist office or a headache center, there's probably a 70% or greater chance that they have medication overuse headache. They eventually get to us, but there aren't enough specialists. So I'm glad people are interested in going into this area. And at the beginning, we knew it was mostly combination analgesics, like the over-the-counter medicines that have acetaminophen, aspirin, and caffeine in them. But then we realized triptans can also do it. And many of these patients have comorbidities. And just like in migraine, they're often depressed or anxious. But with medication overuse headache, they also have dependence type behavior. And they may use too many pain medications. And the treatment, and this article comes from Hans Christoph Diener in Germany, who's very well known in the stroke area as well as the headache area. And he wrote this article in 2016 with many other doctors. And he said, the treatment is patient counseling, starting preventive therapy, and detoxifying them from all medications that they're overusing. And this will come up a few more times in the literature, as I'll show you. Early on in 2004, over on the left, there really was, so the International Headache Society has ICHD. ICHD-3 is the current diagnostic criteria that most of us follow all over the world. And in 2004, we didn't really have a formal diagnosis for MOH. And then there was a diagnosis that came, but one of the problems is they said the patient has to be detoxified, and 2 months later, if they were better, then you could call it medication overuse headache. And we objected to this because we need to make a diagnosis when the patient comes in to see us. So then they changed that and they said that wasn't necessary. And today we have, excuse me, a new set of criteria. So the criteria for MOH is at least 15 days of headache a month over a 3-month period in patients who already have a pre-existing headache disorder. And then you need 10 days of overuse of medicines if they're stronger ones like ergots, triptans, and opioids, but only 15 days if they're taking NSAIDs, aspirin, or acetaminophen. And the old provision that the headache must have worsened with the overuse is gone. The old provision that the headache has to go back to episodic instead of chronic and have much fewer headaches is gone, although that usually happens. And the old linking of different overused medicines to a type of headache problem is gone because patients can have any kind of headache problem, no matter what medicine they're overusing. Well, you know all these medicines. These are the ones that people take for headache. And you may know that the most common medicine for the acute care of migraine in this country is what? Anybody know? I don't mention it by name here, but it's a combination of aspirin, acetaminophen, and caffeine. So that's Excedrin or Excedrin migraine. That's what people take. And some people do fine if they take it once a week for a headache and they get better. But most of the patients I see, if they take it, they're taking way too much of it. And they take it 3 times a day or more for weeks, months, or even years. So over-the-counters are a big problem. Even the NSAIDs, of course, come over the counter. And prescription NSAIDs are also a problem. There's a very good one that I like, which is diclofenac potassium for oral solution. It's called Cambia. And it's great, but people usually don't overuse it because it's been very expensive in the past. I believe it is either generic or going generic. And then there are the medicines we call the F words that contain butalbital, fiorinol, and Fioricet. Those are pretty good medicines in that they do stop headache, and people do love them because they feel better on them. They cause some anti-anxiety effects, which is good, but people tend to really overuse it and they become dependent on it. So I no longer use anything with butalbital in it in my practice, and I no longer use any opiates at all, even though in an emergency room around the country, it's very likely that they will prescribe opiates. Ergotamine tartrate used to do this a lot, but not anymore because most of us don't use the ergots except if we're using dihydroergotamine. We usually have transitioned to triptans and now newer acute care drugs called GPANs. Antiemetics are used a lot, but they don't seem to cause this. They actually can be somewhat helpful when given IV. But the serotonin 1B and 1D agonists, which are the triptans, they can cause MOH. There's a new serotonin 1F agonist called lasmiditan, and its brand name is Rayvow. It hasn't been around long enough for us to know, but it probably causes it, but we don't know that. And the GPANs, ubrogepant and rimegepant, which are Ubrelvy and Nurtec, they do not seem to cause it. They might even treat it. So what are some of the controversies we deal with? Well, when ICHD3 removed the fact that you don't have to worsen when you overuse medicines, I thought that was a problem because I see many people coming to see me who are taking a triptan 3 times a day. That's right, 3 times a day, maybe for 3 or 4 months. They come in to see me and they say, I'm still having little headaches every day, but I'm under good control with these triptans. And I call that medication overuse, but not really medication overuse headache, because they don't have a terrible problem with headache. But I tell them that they probably will develop it, and I try to get them off that. The second thing that's a problem is, do you detoxify the patient or not? And how do you detoxify them? Well, in 2 very famous headache centers, the Danish Headache Center in Copenhagen and Michel Ferrari's Headache Center in Leiden in the Netherlands, they suddenly detoxify the patient. The patient comes in, and unless they're on very strong medicines where that would be dangerous, they say, stop the medicines today. And the patients always get much worse for a while, and they say, you just have to tough it out because you'll be better. And it's true that they'll be better, but we don't like to do that. And I'll show you what we do instead. Do you add a preventive medicine or not? Well, I've always done it, even if it's only for a while, because the preventives really can help the patient to get off the medicine that they're overusing. And when do you add a preventive? Some people add it when they start to detoxify the patient. I add it in advance and build it up to a level, because if you're going to use topiramate, it's going to take at least a month to get them to a good level. You can't suddenly put them on 100 milligrams. But here's what made it somewhat confusing. In Copenhagen, they did a very good trial that had 3 cells. One cell was they withdrew the patient from what they were overusing and they added the prevention, just like I would do. The second cell, they gave the preventive treatment, but they didn't withdraw them. And the third cell, they withdrew them, but there was an optional preventive treatment 2 months after the withdrawal. And they say in this paper that all 3 did about the same. I find it hard to believe, but that's what's in the literature. Now, part of the epidemiology is other people in the family may have the same issue. There's a 3-fold increased risk of developing MOH if there's a family history of MOH or substance abuse. And this one's really surprising. There's a 4-fold increased risk of getting drug overuse or developing drug overuse or substance abuse if another member of the family has MOH. Now, these were done many years ago, but still, it shows that it may run in families and it may be inherited to a certain extent. Now, this gentleman whose name you see at the bottom, if any of you are from Thailand, you can pronounce this for me because he's a friend of mine. And when I asked him, how do you pronounce your name? He said, just the way it looks. And I've always had trouble with it. I might call him Sri Kiatchachorn. I first met him 10, 12 years ago when he came to the US and presented his studies at the American Headache Society. And in those days, he was studying Worcester rats. And he thought that there was an upregulation of a pro-nociceptive 5-HT2A receptor. And he thought that was a big reason that there were medication overuse headaches. He also found that there was an increase in cortical spreading depression frequency, and this seemed to facilitate trigeminal nociception. And we know today that the trigeminal nerve, especially the trigeminovascular system, which is the first branch of the trigeminal nerve between the pons and the brainstem and the periphery, which we're talking about, the meninges. So that first branch, including the trigeminal ganglion, is the most important area for headache in general, especially migraine, but especially for MOH. Of course, the brainstem is important and the thalamus is important, and you need the meninges as well. But this is a very critical area. He's done some further work, which he has published, and I've published with him, as I'm going to show you. And today he might say a few other things. He'd say that chronic medication exposure seems to interfere with the endogenous serotonin-dependent descending pain control system, or DNIC, diffuse noxious inhibitory control, which, if you're interested in pain, you've read about this. Headache doctors are just catching up with it now. So that's interfered with, and that doesn't help get rid of the pain. And then these altered endogenous control systems lead to other problems, including upregulation of CGRP neurotransmission. And CGRP, we know today, is very important in headache. We didn't know that 10 years ago. We knew it might be, but we know a lot more about it today. And he also feels that this facilitation of trigeminal nociception at the brainstem level, at the trigeminocervical complex, way down in the brainstem where it meets the spinal cord, is also important, and that there's increased hyperexcitability of the brain and brainstem, leading to susceptibility of cortical spreading depression. And all of this is in an article written by Sun Edelstein, myself, and these two other Thai doctors, which came out just several months ago in CNS Drugs, if you want to read more about it. And here's a figure from it. Over on the left, you see it enhances CGRP neurotransmission. Up at the top, you see it enhances cortical excitability. And on the right, it decreases diffuse noxious inhibitory control. Well, what is this syndrome? If you haven't seen it before, remember, it occurs only in people that have pre-existing chronic headaches. If you give too much aspirin to somebody that doesn't have headaches, they don't develop MOH. Years ago, when we didn't have good arthritis drugs, we used to give people up to 12 full aspirin a day. Of course, they had trouble with their stomachs, but they wouldn't get headaches if you did this unless they had migraine. And the people that have MOH wake up in the morning and they have a bad headache, so they take 2 pills of something, either over the counter or prescription, and 3 to 6 hours later, they take more, and 3 to 6 hours later, more. And before you know it, they're not only having a lot of headache, they're getting worse. And usually the headaches will increase in frequency and intensity over time, and they become refractory to the acute care medicines and the preventive treatments. And when you try to take them off the medicines, they always get worse for a couple of weeks. So when the patient comes to me and I talk to them about this, they say, well, I've done that and I just got worse. And I tell them most of the time, the worsening stops after 2 to 3 weeks maximum, and you didn't get that far. So that's why you didn't get better. You're going to have to hang in there. And if you detoxify them, you will get them down to much fewer headaches. They'll go from chronic migraine to episodic migraine, and preventive medicine usually helps. So for years, I've been following this very carefully. I educate the patients because if they don't understand why they will get worse first and then they will get better, they're never going to listen to you. You must detoxify them. And I've been doing that for 40 years. And you start a preventive medicine at the beginning. Well, in Copenhagen and Leiden, they abruptly discontinue them from what they're overusing, unless they're on butalbital or opiates or benzodiazepines. And then you have to go more slowly. And I always used to start the prevention early, but most doctors in this country start it just when they detoxify them. And I'm going to talk to you about bridge therapies that can help them get through this difficult 2 to 3 week period. Now, don't forget the biobehavioral techniques. Everybody jumps on medicines, but you could teach your patients to avoid certain headache triggers, which will help them. Remember to teach them to eat on time, because migraine patients will clearly get a headache if they miss a meal. And they should exercise regularly, and they have to sleep well. And many of them don't sleep well. So we need to get into sleep hygiene with them. They must keep track of their headaches and how much of these medicines they're using. So you should have them keep either a paper tablet of that, paper tabulation of that, or today there are many apps, and apps are very helpful for these patients, because when they come back to you in 2, 3 weeks and you say, how are you doing? They say, well, I think I'm better, but you have no data of how many headaches they're having in a month. And if I say, have you cut down on those Excedrin you were overusing? They say, I think I did. You want to know exactly what they've done. Biofeedback training and stress management is very helpful in headache patients. Cognitive therapy, psychotherapy, and today mindfulness can be helpful. Physical techniques like physical therapy and manipulation and Ayurveda, all of that can be helpful, but there's not a lot of good literature on how well it works. But patients often like it, so that's fine. And some of these therapies are in our literature, and I have used them on occasion: vitamin B2, magnesium, feverfew, petacites, hybridus, melatonin, and coenzyme Q10. Some patients say, I don't want to take any medicines that can cause side effects. You can try these, but in my experience, they don't work as well as our medicines. Now, if the patient is going to be detoxified from butalbital, you might want to switch them to phenobarbital, which has a much longer half-life and it's easier to detoxify them. So for every 100 milligrams of butalbital, and there's 50 milligrams in each one of those furanols and furosets. So for every 100 milligrams, switch them to 30 milligrams of phenobarb, and then slowly taper them over 10 days and they'll be fine. If they're on a benzodiazepine, you can taper them very slowly or switch them to clonazepam, which is a little easier to regulate. If they're on opiates, I used to actually take them off over a 10-day period by going down 10% a day. But when I lectured on this last time, somebody who was an addiction specialist said, you really have to do it over a month. But there we're talking about people who are really addicted and dependent. The headache patients are usually just using too much for the last few months, and they're not really addicted to it. But I think that was a very good comment. So I would say do it more slowly if that's appropriate. If it's over the counter, you could stop them suddenly. I'd be very cautious if they have caffeine in those medicines, because caffeine withdrawal can be extremely difficult. Ergotamine tartrate isn't used much, but if you can switch them to DHE 45, and you don't have to give it IV in the hospital, you can give 1 milligram subcutaneously once or twice a day for a few days, and that can be very helpful. And if they're on triptans and they're overusing it, you could give them DHE or give them some of these bridge therapies that I'm going to talk about. Now, one of the best bridge therapies is actually the triptans if they're not overusing it. If they're overusing NSAIDs or opiates or other stronger medicines or even over-the-counter medicines, you could give them a triptan twice a day for 10 days or a week, as long as their heart is okay and they're not stroke prone, because it'll probably help them. And we're not going to do it for too long. You could give them NSAIDs 2 or 3 times a day. You could give them a jolt of steroids for 5 days. You could start some DHE on them, or you could also, in addition, use some atypical neuroleptics. I happen to like quetiapine, but you could use any of these. And if you give prochlorperazine IV or even promethazine IV, that's what they do in a good emergency room. That really works, but you can't really tie them up to an IV for 2 weeks. Here are some of these bridge therapies that you can give IV if they happen to be in the hospital. You can give dihydroergotamine. If there are some Brazilians in the audience, you probably know dipterone. That's their favorite drug. Divalproic sodium IV, Depacon can be helpful. I like dexamethasone, but a big dose and then get them off it in 5 or 6 days. Ketorolac, prochlorperazine, as I mentioned, metoclopramide is a good one. Diphenhydramine, IV magnesium. I don't use propofol, but occasionally we use ketamine in really difficult patients. Here's another interesting article from Ferrari from the Netherlands, and he's a really well-known guy. And he wrote this paper just 3 years ago, and he said he thinks the mechanism of medication overuse is due to a changed sensitivity as a consequence of central sensitization in the brain, and it affects our sensory system. And he says detoxify them, and remember, he does it abruptly most of the time, and he says educate them, because you must tell them what's going on. I'm not sure he really even cares that much about prevention. And one last paper I want to show you. This is Hans Christoph Diener again from Germany, and David Dodik and others are on there, and David's from Mayo Clinic, and these are very well-respected doctors. And you see, they say up in the upper left, if the patient has medication overuse, and on the right of that, it says they're probably overusing opioids, barbiturates, or benzodiazepines, but it could be other things as well. Educate and counsel them, withdraw them over a period of 2 to 4 weeks. And on the left, you see, you could give prevention, topiramate, onabotulinum toxin A, the monoclonal antibodies, and other CGRP medication. And on the right of that, you see, don't forget the biobehavioral preventives. And down at the bottom on the left, it says, if they don't respond or they don't tolerate this well, consider putting them into the hospital. And we used to do that much more frequently in the past, and they still do it sometimes in Europe. And there are some places in the country, but very few today, that actually specialize in that. Well, let's talk about what we do today. Now, I will admit that you can give somebody with MOH topiramate and get it up to a good level, 100 milligrams or more a day, gradually, or give them onabotulinum toxin A, or give them anti-CGRP monoclonal antibodies, and it may reduce their headache or migraine attack frequency, and it may reduce the amount of medication that they're taking. But I can tell you, over many years, I've given topiramate and many other preventives. I've used onabotulinum toxin A, and it can work, and it works somewhat, but it doesn't usually do the whole job. So I want to talk to you a little more about what does the whole job most of the time, not always, the anti-CGRP monoclonal antibodies. They seem to cause much decrease in headache, even if the patient is still overusing medication. And they get back from chronic migraine, more than 15 days of headache a month, to episodic migraine. And they have much fewer headaches. And the interesting thing is, they also stop using the acute care medicine so much, even if they were taking good ones like triptans or ergots, they start using fewer of them. I don't think I have to tell you about this, so I'm not going to spend any time, but there are four of the monoclonal antibodies. Erenumab, Erenumab or Aimovig is the only one that actually sits on the CGRP receptor and prevents the CGRP from docking there. And the other three, Erenumab, Galcanezumab, and the IV one, Eptinezumab, they all grab the CGRP coming out of the end of the trigeminal nerve and the trigeminal vascular system and prevent it from docking on the receptor. Well, let's look at a little bit of the literature. Many of you have probably seen this from Erenumab. It was the first one of the monoclonals to be approved by the FDA. So many of you have probably seen this data, and it's from a large study on 667 people done for migraine. And some of them were given the 70 milligram dose, some the 140 milligram dose, and of course, some got placebo. And they were looking for, the primary endpoint was reduction in the number of migraine days in the month from however many they were on. They wanted to see a significant reduction, better than placebo and better than the run-in time when they weren't on any medicine. So the upper graph shows those that had no medication overuse in that study. And the very top tracing is, of course, placebo. And you see placebo works a little bit at 1 month and a little better at 2 months, and then it levels off. But the two levels of drug, 70 and 140 milligrams, works much better than placebo at 1, 2, and 3 months. But look at the bottom curve. These are the patients with medication overuse. And not only are they doing better, but they're doing better than the ones that didn't have medication overuse, headache. So at least that means that this works on them. In fact, it works very well on them. And here is the same trial, but here we're looking at the decrease in the number of specific medication days in the month. So if they were using triptans, maybe they went from 20 days a month of using triptans to 10. And in the top tracing, placebo works a little bit. The lower dose works better than placebo, but not too much better. And the higher dose works even better yet. And down at the bottom, even though it says without medication overuse headache, there was actually a misprint in the Journal of Neurology, believe it or not. Those patients did have medication overuse, and you see that the two doses work much better than placebo. So my takeaway from this is you're going to get better by using this particular drug and much better than placebo. And even if you don't detoxify the patient. Now, one more I want to show you is about Erenumab. And this is a secondary endpoint that all of these monoclonal antibodies looked at, and that is the responder rate. What percentage of patients have a 50% decrease in number of headaches? So if they started with 20 headache days, 20 migraine days a month, if they got down to 10 or 9 or 8, that was at least a 50% decrease. So let's look at the right side first, which is patients without medication overuse. 41, 42% of those patients had a 50% decrease in the first month when they took it either quarterly or monthly. Remember, Erenumab is the only one, the subcutaneous one, that can be given once every 3 months. The other two subcutaneous ones can only be given once a month. And if you look over on the left side where they did have medication overuse, The numbers are almost the same. And if you look at the placebo rates on the two sides, over on the right, there's a higher placebo rate of 22%. So we always look at the delta, the difference between the real drug and the placebo. And over on the left, the placebo is so much lower that the delta is very comparable to the right side. So my takeaway is these monoclonal antibodies, no matter which one you give, will really help the patients with medication overuse headache. A specific trial done just on MOH hasn't been done yet, but I think that's coming. So let me summarize. You must educate the patient with MOH because most of them have tried to detoxify and failed. And if you tell them why you need to do whatever you're going to do, they're more likely to stick with you. I've had many patients, even after discussion, run out and never come back to see me again. And I'm sure they continue to have their bad headaches. Remember the non-pharmacologic techniques and behavioral strategies. They can be very helpful. Identify and address psychosocial comorbidities, because if you make their headaches better, but they're having trouble with their spouse or a serious psychiatric problem, they're not going to get all better. Detoxify them most of the time. But in my experience now with the monoclonal antibodies, I don't struggle with the detoxification. I just say to them, I'd like you to use less of that medication and you will have fewer headaches. And if the headache is milder, don't take anything for it. You're going to get better on your own after your injection. And I start any one of the monoclonal antibodies against CGRP. Remember to follow the patient up in 2-3 weeks. If you just give them a shot and send them out, which sometimes you have to do because you're too busy, they may get into trouble again. And then finally, my conclusions would be these are very complicated patients that we often couldn't make better. Most classes of acute care medication, if overused, will make these patients worse, except probably the newer Gepants, Ubrogepant and Rimegepant. They haven't really been studied properly, but when you give them every day or every other day as a preventive, they do not cause medication overuse headache. And I think they may even treat it. If you have to detoxify them, that's the cornerstone. But with the new treatment, it'll happen on their own. I still like preventives, but now I like the monoclonals. There is a need for comprehensive treatment strategies in some of the patients, and they may need aggressive outpatient or even inpatient therapy, but very few now. And pharmacologic interventions and behavioral interventions are important. And I used to say 75% of the patients will get better. Now I say closer to 90%. So let me stop here. And that's everything I wanted to discuss with you. And maybe you'll have some questions that I will try to answer.
Thank you, Dr. Rapoport. That was a very interesting lecture. So
you.
the microphone is open for the audience to ask any questions.
Hello.
Hi.
Hi, Dr. Rapoport. Thank you so much for the session. I am
welcome.
Aparna Paryadit. I'm an international medical graduate currently applying for neurology this season. So
And where does that very interesting name come from?
That's actually my family name, the surname, and Aparna is one of our Hindu goddesses' names. So yeah, thank you for asking.
Okay.
So my question is that you happen to mention that under biobehavioral prevention, that the patient needs to eat better and exercise regularly. So my question is that, has there been any solid study on the correlation between BMI and the predisposition to MOH?
There've been a few, I don't know that I would call them solid. And where I started to see them about 10 years ago are actually came from surgeons that were operating on obese people and doing banding and other techniques. And I saw a few studies that actually showed those obese people that happen to have headaches actually had fewer headaches. But is there a great study done by headache specialists that really proved that? I would say either I haven't seen it or no, maybe it doesn't exist. And the other thing that I wanted to talk about there was, we know for a fact, and I'm not sure this has been studied properly, that migraine patients, if they miss a meal for a long time, like doctors who get very busy, and many doctors have migraine, if they can't eat on time, what happens? You get a migraine, it'll trigger a migraine. So food has a lot to do with it, but the corollary to that is I get asked all the time, well, which foods and what diet can I go on? There's never been a great study on, there's been 500 studies on diet, but they all say something different. So I just say to my patient, if you know that half a glass of red wine gonna cause you to have headache, please stay away from it, or at least you know what you're getting into. But there's no one diet that works on everybody. But yeah, you asked a very good question. I think losing weight is helpful, and exercise also. And there haven't been great studies on that either. But we all take these very difficult patients who never exercise and get them very slowly to exercise. And that's part of the treatment.
Yeah.
So thanks for the good question. And you see, I did put in Ayurveda there because I've been to India 8 times and everybody uses it there. And I have nothing against it, but I really don't understand it myself.
I understand. Thank you so much. Thank you. Have a good day.
Welcome.
Thank you.
Yes, you too.
Dr. Rapoport, there is a question from the chat. This is from Dr. Chari. How long does one continue the preventive treatments for MOH, such as topiramate or monoclonal antibodies?
That's another very good question. So before the monoclonal antibodies, when everybody was either getting a beta blocker or topiramate or other anti-epileptics or antidepressants and so on, I would go 6 to 12 months at least. And the more difficult the patient, the longer I would go. So sometimes 1 to 2 years. And then I always like to say to patients, well, you've been on this long enough. You've really done very well. Should we try to decrease it slowly? And I don't like keeping people on medicines if they don't need it. And the only way we would know would be to take them off. I have a problem now. When I put someone on a monoclonal antibody and they do really well, and the company pays for it, or the insurance company pays for it, and there are no adverse events, when I say to them at a year, you know, you're not only 50% better, you're 80% better than you were, and you're really doing well. Let's start to slowly decrease. Let's go from 1 month to maybe every 6 weeks, and then every 2 months. They don't want to come off. They say, why should I come off? I'm not having any problems. This is $600 a month, but somebody's paying for it. Why should I come off? So I have to tell you, I've been using these for well over 3 years because we did the original study starting 5 years ago. And so I was able to put people on very early. So I have some patients that have been on them for 5 years. I rarely can take a patient off. They don't want to come off. Now, if I insisted, they would do it. But I ask you, why stop it if it's working and they're not getting side effects and it's covered? So that's a problem because it has increased the cost of medicine, but it's helped these patients.
Okay. There is another question from the chat. The question goes like, since placebo has such a noticeable therapeutic effect, are there any known mechanisms of a placebo effect that we can utilize in MOH?
That's a good question also. You can read about placebo. It really works. And when you give a placebo tablet, even if you say to the patient, I'm giving you a placebo, they may get better to a certain extent. And there is very good literature on why they get better. And it does work on their endogenous pain control mechanism and so on. a very interesting topic. And yes, headache patients in an acute care trial, you want to keep the placebo 30% or lower. In a preventive trial, especially these double-blind preventive trials where you're going for pain freedom at 2 hours, which is really hard to make, you want to keep your placebo rate down to 9 or 10%. So yes, you are, as a treating physician, the best placebo in the room. If you encourage your patient and say, I've had a lot of success with this, not everybody gets better, but the majority of my patients get better, and they not only get a little better, they get a lot better, that's going to have a big placebo effect. Other effects you could read about more. I don't really know what else to tell you, but there are people who specialize in decreasing the placebo effect for a clinical trial. And many companies go and pay a lot of money to these companies and say, please train us on how to keep the placebo effect down. Because if you're running a clinical trial and if you have a new drug that you want to get approved by the FDA, you need a low placebo effect. So are there doctors that can teach you how to do a high placebo effect? I think PhD psychologists are good at teaching their patients, and maybe some of the ways to do it aren't actually placebo at all. They say you should have your acute care medicine ready, and you should not catastrophize during the headache. You should say, I've got a plan of 6 things I'm going to do. I'm going to lie down for a few minutes. I'm going to take my medicine. I'm going to shut the lights off, and so on. So I think behavioral medicine treatment will also teach your patients how to have a better placebo effect.
Okay, are there like any other questions from the audience?
I have a question. Dr. Rapoport, thank you for a wonderful lecture. And I wanted to ask if there is any research has been done about the success and failure rate of the MOH treatment in other treatments, like other than MAPs. Thank you.
I'm not sure I understood. You're asking me, other than monoclonal antibodies, have there been literature on how to treat this?
No, the
No.
success and failure rate of the
I'm not catching that. The what rate? Can you say that again?
success and failure rate of the MOH treatment under different types of methods apart from
I
the...
really apologize. I'm not picking up that word. Could you spell it for me? I really apologize. I'm not understanding what rate you're talking about. Could you say it in another word, or could somebody else help me?
Can you hear me better?
Maybe. Just say the first part of the word so I can get it.
Sergio, can you please help me?
Yes,
Yeah, I apologize. I'm just not picking up that one word you're saying.
No problem.
so it's about successful failure rate with other type of treatments for the MOH. That's the question I had.
Maybe it's too early in the morning for me. I'm having trouble understanding the question. Can you rephrase it some way? I'm sure it's a very good question, but I don't understand what's being asked. Try one more time. What rate are we talking about?
Yeah, success rate of the treatment.
Success rate.
Yes, of the treatment of MOH apart from the monoclonal antibodies. I saw the research which you
now I
in
understand
your lecture, right?
Yes.
On
So
there's
there's been a lot written about Botox, onobotulinum toxin A, and you can read about that by just looking it up. And there's been a lot written on topiramate as well. And when you read those articles, you'll see that it is helpful in MOH. Personally, when I give somebody those two treatments and don't detoxify them, I don't believe, in my own experience, that the success rate is high enough. And actually, when somebody comes to me already on Botox, I say, well, why are you here? You're on a very good drug. And they say, well, I've been taking onabotulinum toxinate for 2 years, and I'm definitely 40% better than I was, but I'm still having too many headaches. And I will often add a monoclonal to them, and then they will get considerably better. And then I have to decide, will the insurance company let me keep them on both? So I'm not saying that older preventive drugs don't work. In fact, they do work. But if you have somebody that's really taking 6 or 8 tablets of anything a day for a year or two, too many tablets for a year or two, and they have MOH, no matter what you give them, if it works, great. But I think the success rate of those patients will not be as good as if you put them on MOH. But I haven't done my own study, and you can read about it in the literature. But we need new studies that show exactly that they were on one of those, and then we added a monoclonal. Did it really help in a double-blind study, or at least in a well-controlled study? And personally, I think you'll find some percentage of patients get better on the older drugs, and more will get better if you add the monoclonal or switch to the monoclonal. And I apologize for not understanding that word success.
Okay, Dr. Rapoport, there's another question. What is your experience with non-pharmacologic treatment like cephalin or VNS stimulation in these patients?
My experience is very large with behavioral medicine treatment, because I had 2 PhD psychologists working with me for 30 years when I was in Connecticut, and they are still in my old headache center there. And they were specialists in biofeedback training, cognitive issues, visual imagery, and just explaining to the patient how to get through a migraine attack and so on. That's been my experience, not any kind of stimulation, but biofeedback training. And I will tell you that with children, I almost never put a child on a preventive medicine. I just sent them for behavioral treatment. With adults, about 50% of them, I sent them for behavioral treatment. Some of them needed medication as well, some of them didn't. So I have a very high success rate, and the literature is replete with, yes, medicines help, behavioral medicine helps, and the two together help even more. I hope that answers the question.
Okay, and there is one more question that's coming from the chat, Dr. Levine. Are 3 times definite contraindication in patients with history of cerebrovascular disease or stroke?
Yes, if the stroke was caused by a lack of blood supply to an area, unless it's way far away from that incident. The answer is probably no. If it was caused by a bleed from an aneurysm that's been treated and cured, coiled, encapsulated in methacrylate, or removed completely, I wouldn't hesitate to give them. But if you're talking about stenosis that's still there, I probably wouldn't give it to them. If you're talking about, I just saw somebody at UCLA yesterday who had complete occlusion of the internal carotid artery going way up into the head, but never had a stroke and was coming in for something else. And we found it incidentally. And the other arteries look good. So if the other arteries are good and this person had a complete occlusion, Although most people would say no, I would say, why not? So that's my answer. There are contraindications like high blood pressure that's not controlled and any acute treatment. Any patients that have decreased blood supply. So unfortunately, I'm going to have to go because I've got some other things I've got to do this morning, but it's really been great to come back to Downstate. And thank you very much. I had a wonderful training there, and I hope everybody learned something from my lecture today.
Thank you so much, Dr. Rapoport. It's been a very interesting lecture, which hopefully we're going to see you sometime in a Downstate in person. Thank you so much.
I may just come when we get rid of our COVID. I may just come and visit again and be glad to talk with you at that point.
Sounds. Thank you so much. I had a wonderful day. Thank you for the audience.
Great. You too. And goodbye, everyone.